You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome to CRST, the podcast. I'm Dr. Gary Wirtz, and I'm so excited to be able to host this edition. We're talking about emotional intelligence and managing patient satisfaction and dissatisfaction. I'm really thrilled to be able to give a little bit of perspective on this beyond what was just in the article. I'm also really honored to be joined by my dear friend and mentor, Dr. Eric Donenfeld. Eric, you need no introduction, but you are the founding partner of Ophthalmic Consultants of Long Island, past president of AAO, ASCRS, former editor-in-chief of CRST, and the list goes on and on. But more than that, you've been a good friend to me over the years. Always enjoy our conversations, and thank you so much for joining us on the podcast.
Gary, it's a pleasure to be with you. And the reason that I think you and I get along so well is I think we're basically cut from the same cloth. We have the same perspective. When I listen to you talk, I'm saying to myself, that's exactly what I would be saying. And you are the next generation of leaders in ophthalmology that are going to understand the value and the importance of doing the right thing as an ophthalmologist. So thanks for everything you do.
Absolutely. And I will just say this, and I've said this many times, it's leaders like yourself and others in the industry, or, not in industry and in our profession, who have, been the giants we've stood on your shoulders. So we wouldn't be here without the work that has been done and what's been paved before us. So with that being said, I want to set the stage for this conversation. Emotional intelligence is something that I think we all experience, but we may not always be able to put our finger on what it is we're experiencing. We can sense when someone cares about us, but we don't exactly know what it is that we're sensing. We also can sense when people are frustrated, or perhaps there's a disconnect between something that we're expecting and something that we're receiving, whether that's in a customer service area or if it's in surgery, it becomes even more important. I think one of my most foundational lessons in this, other than just being a physician and experiencing this daily, is actually it was at a Johnson & Johnson a Catalyst users meeting that was set up in New York, and we were both on faculty. And I'll never forget one thing you told me, and we were just you and I were just shooting the breeze. And I was talking about patients and how to make patients happy, and I was sort of just probably pouring my heart out because that it's a topic that I'm always bothered by when a patient isn't happy. And one thing you told me, you said, Gary, never let a patient complain. And I just thought to myself, what does that mean? Explain more. I wanted to dig into that a little bit. And he said, well, and you outlined it very nicely in the article, which we'll get into. But you said, as soon as a patient complains, you have an adversarial relationship with them. You need to walk into a room and tell the patient why they're unhappy. You need to communicate with them that you understand why they're unhappy. And if they know that you know why they're unhappy, you can build a bridge. And that little conversation we have, I'm not sure if you recall it or not, but it really was something that set me on a pathway of trying to build a therapeutic alliance with patients rather than being frustrated with them. And that sort of led me down really a pathway towards exploring this more. And that's why when I was honored to be able to be the guest editor of CRST, I wanted to explore this with a lot of our friends who made amazing contributions. If anyone hasn't read through the issue, I would highly recommend it because I think any refractive cataract surgeon or doctor in general would benefit from that. But will you just give me a little bit of how you came up with that? Because to me, that is a real key insight, and we'll sort of build on that. When did you realize that, or was there a moment or a time when you felt like this is an important thing, I need to shift my approach?
Saying, Gary, I think it's been over time that this has developed, but I came to the realization several years ago that in dealing with patients, the most important aspect of the relationship with a patient is to make certain that the patient always understands that you and the patient have mutual respect for each other and that you are on the same team looking for the same result. When a patient comes to me, sometimes they're angry, and it may not be a patient I operated on, it may be a patient that someone else operated on. They're angry, they don't have the result they want, and the concerns may be what you might consider trivial, or it may be extraordinarily important, but it doesn't really matter what you think. It's really what the patient thinks, and you have to respond to that. And what I found is that the first key to developing a relationship with patients is to be on their side, to be their ombudsman, to be their advocate, and to make certain that the patient knows that no matter what happens, you and the patient are aligned with the same purpose, and that's resolving the problem. And even if you can't resolve the problem, as long as the patient knows that you're doing everything you can do, it's gonna help resolve the problem. Some doctors will become confrontational. They'll approach a patient who's angry with them by becoming angry themselves. And once that happens, and the doctor and the patient are adversarial, no matter what happens, even if you resolve the problem successfully, that relationship has been broken to some extent, and it's almost impossible to repair it. My feeling, as you said before, is that when a patient walks into my practice and they're unhappy, I don't give them the opportunity to complain. I walk in and I make certain that they know that that we're on the same side. And this really involves a key aspect, and that is your staff has to work with you on this. And my staff is extraordinarily important in making certain that I'm aware of problems before I walk into a room. Because you and I both know that the worst thing to do is to walk into a room expecting to have a patient who's going to be happy, and they're just scowling at you. You go to shake hands, they don't want to shake hands with you. They're just annoyed. I want to know about that patient before I walk in. And my patients who walk in who aren't happy, they get a workup so that I walk in with answers for them. The last thing you want to do when a patient's unhappy and they say to you, "What are you going to do about it?" And you say, "Well, I don't really know. Let's run some tests." I don't want to ever say that. I want to walk in and I have an answer for them. I know what the problem is. And some of the very key simple aspects of the workup that's done by my staff before I see the patient is I want a refraction, I want a topography, I want an OCT of the macula. I want to know if there's a retina problem, an ocular surface problem. Um, I want to know all these things before I walk in, so that when I walk in, I have answers. I'm telling the patient that I understand why you're unhappy. I would be unhappy as well, but you and I will work together to help solve these problems.
Yes, absolutely.
When I consult on a patient, particularly a patient having cataract surgery, but it applies to all surgery, including refractive corneal surgery, when a patient walks in my conversation with the patient, I go through the risks, I go through the benefits, I go through the education that I think is really important for patients. And then I always finish with the last aspect of my conversation is I want you to understand that I'm going to do everything I can do to give you the outcome you're looking for. But 20% of my patients don't get the outcome they're looking for the first time around. And that you have to understand that cataract surgery, by its very nature, isn't as accurate as we'd like it to be. And that sometimes I need to go back and do something else that's going to make your outcome better. I usually wait a month or two after the surgery, but if I tell you a month or two from now that you might need another procedure, just consider that part of the process of getting to where you want to be. And I will I will do everything I can to make certain you get the outcome, and I will leave no stone unturned. And that's the last thing I say to the patient when I finish my consultation, that they know that there's a possibility they may not be happy the first time, but they know that there's a process to resolve the problem.
And I love the fact that you're putting 20% on it. There's something, when I would tell people, this is before I was really doing multifocal lenses much, I was doing some monovision. I told them it's an 80% solution to your vision. And, 20% of the time you're going to want to wear some glasses for this, that, and the other. But you know what? I was underselling monovision, and they would come back and be happy to report, I almost never need to wear my glasses. You did really good. I said, well, you're just a great patient. You've done so well. You're really ahead of the curve there. And so I think giving them a number that doesn't seem like zero. something, a non-zero number, they're not going to immediately think, oh, something horrible has happened. I'm the one exception, and I have to, now this is a catastrophe in their life. Because you're exactly right. When somebody comes in and their expectations have not been met, which is one of the things that you talk about in the article, that the primary factors that influence patient satisfaction is basically the health of the eye, the surgical outcome, and the patient expectations. So it's like expectations minus outcome. And so basically, when someone is dissatisfied, they are looking, number one, to know that you know why they're dissatisfied. And that's something, if you've read Chris Voss, I'm not sure if you know Chris Voss, he's a former FBI negotiator. He has this book called Never Split the Difference, which I love. And I took the master class. Sometimes it does feel like we're negotiating, with hostile parties, if you will. And so how do you turn the temperature down? And one thing Chris Voss talks about is labeling. And when you label someone's emotion, you're not agreeing necessarily with their reasoning or thinking behind what is there, but you're saying, I understand that this is your present state. So telling someone, you seem upset, you seem disappointed, you seem frustrated, you seem like maybe we've tricked you, and I would be frustrated too. And that's kind of exactly what you got into when you were saying, tell a patient why they're upset. That way they don't have to tell you. That's really, when I took that master class and read Chris Voss, I had that insight. That's what Eric was talking about. You're labeling and letting them know you understand. And then the second thing that you mentioned is you're coming in with answers, because patients want hope. When someone is frustrated, they're not frustrated because necessarily of the outcome, but I think that they have this sense that I have a problem with my vision, and I don't know if it's ever going to get better than this. Something horrible has happened. My surgeon, depending on how their interaction was with their surgeon, they might think my surgeon has given up on me, or I picked the wrong surgeon, or I didn't do the right research. They're either blaming themselves or others, but there's this catastrophe that they're facing in their mind. And one thing I tell patients sometimes when it's like a multifocal patient or someone who's really, really close to their refractive result is, I tell them, your vision, imagine an old analog dial on a radio. We're really close to tuning it perfectly. You can hear the music, but you're kind of focusing on the static. And all we need to do is turn that dial just ever so slightly, and we'll get it just right for you. But right now you're hearing the static, you're not hearing the music. And I feel like sometimes those little sayings or analogies can help people reframe what's going on.
I love that analogy. The problem is going to be is that a few years from now you can't use it because no one's going to know what a dial radio is. I do agree. It's exactly, that's perfect. I haven't heard that before, and I love what you just said, which is it's exactly right.
So one thing that you've also talked about is managing an enhancement. Talking about there is that potential. We're going to need to go back. When someone comes in, let's say they're 2025 or 2020 unhappy, we just walk through your decision tree, whether you're going to take on that, let's say, plus a quarter, minus 50 and go to LASIK, or whether you're going to coach them through that maybe an enhancement procedure isn't the best thing for you. When do you consider doing an exchange, and how do you manage the perception of I guess the overall experience of the patient? Sometimes patients just they think they know what they want, but they don't necessarily understand that doing more surgery has risks as well. Can you talk through your thought process on that?
Well, yeah, that's really obviously crucial, Gary. And when I have a patient who's unhappy, I want to evaluate precisely why they're unhappy. And I have what I call the 5 C's. I've actually expanded it to 6 C's. When any patient who comes in who's unhappy after cataract surgery, particularly, I go through in my mind the C's. And the C's are cornea and ocular surface disease, the capsule, cylinder and refractive error, CME, centrational lens, and the sixth one, I'm not sure how to work this in here, but it's clouding of the vitreous. We'll make that the 6C, clouding of the vitreous, which is a new one for me. I really wasn't that aware of it until a year or two ago of what a primary role vitreous condensation plays in unhappy patients, particularly with multifocal. So I go through that list in my head of what needs to be done, and the one that's the easiest is refractive error, because you can just it's digital. You see what's there, and then you have to decide what the risk and benefit is to the patient to achieve the outcome that they want to achieve. And while I'm a big advocate of corneal refractive surgery, LASIK, and PRK, I'm also realizing that for some of these small treatments, the results can be suboptimal. um, I do like relaxing incisions. It's kind of old school, but for a residual cylinder, a small relaxing incision, very commonly I do this at the slit lamp, and I might do 5 to 10 a day, is a wonderful procedure with very little downside risk to these patients. You're operating near the limbus. There's very little risk of perforation. And I have zero tolerance for astigmatism. When we talk to patients, we talk among ourselves, we say that, if you get to within half a diopter of cylinder, we've met our goal. I don't think we'd be happy with a half a diopter cylinder off on our glasses, certainly. And my perspective is that if a patient is happy with some residual cylinder, why not make them ecstatic? And the take home message that I think I've stressed before is that there's a misconception among ophthalmologists that if you make a patient happy, you're going to be successful in your career. And uh, actually, that's not true at all. Making patients happy is the bare minimum you can have to be in practice. If you don't make patients happy, they don't come back to you. So you've got to make patients happy to just exist. The way you grow an extraordinary practice is you exceed their expectations. It's a little hackneyed. It's an old-fashioned saying. You hear it all the time, exceeding expectations. But that's my goal on every patient. I look at every patient as an opportunity and a challenge. What can I do for that patient to give them better vision than they thought was possible? And a small LRI might be possible, managing the ocular surface and dry eye. Obviously, the capsulotomy is important. And sometimes when I can't find anything and everything else has been exhausted, vitreous condensation really does play a significant role in unhappy patients. And that's when I have a conversation with the patient. I think to resolve your problem, we need to offer you a fairly significant surgery. I'm a believer in optical vitrectomies, and we have many of my partners do this routinely, and I have seen extraordinary results with optical vitrectomies. But then the patient has to realize they're going back to the operating room. It's not a small procedure that they're having done. But for those patients who are really unhappy, where that's the underlying etiology, that's another conversation that I have pretty routinely, and I've really been happy with my results. What has been your approach to patients who have vitreous opacification?
At first, I would try to see if I could see what they were experiencing. And if I could see it, and I would basically have them at the slit lamp, and I would have them look left, right, center, trying to kind of get the vitreous moving. And if I could see clouds moving back and forth, that gave me a pretty good idea that what they're seeing is probably, what I'm seeing, and a vitrectomy is going to help. I also really try to get the right history, because sometimes fluctuating vision is the complaint, which you think is ocular surface. But fluctuating vision can also be from vitreous fluctuating inside the eye. And depending on the way it's arranged at the moment, the vision can be good or bad. So I've actually taken a little bit more of an aggressive approach, where if the history sort of matches, they say when I look one way, I'm sort of seeing something that sort of follows me. And I look back, it sort of trails and kind of catches up with where I'm looking, even if I can't really see what's going on. If it's a multifocal lens in particular, I'm very quick to recommend a vitrectomy. I've got great resources around me. John Kitchens is 20 minutes across town, so I've got some of the best, and his partners. So we got great retina resources here in Lexington. So it's easy for me to say, I think this will be helpful. And same thing, I've been blown away with how helpful it can be to patients. And so again, as we get smarter, technology evolves, we're able to actually meet patient expectations to a much higher degree. I just think about 15, 16 years ago when I was starting practice, which I know doesn't seem that long ago, probably in the grand scheme of things, no one was thinking about vitrectomies for multifocal lenses. We didn't have trifocals. There was no femto. There's a million things that were not there. And I think how far we've come in the past 15, 16 years since I finished training, it's crazy. But yes, to finish the point, I strongly believe that especially in diffractive multifocal lenses, vitrectomy can be a saving grace. And I would definitely do that before I went straight for a YAG. I've said this a lot. It can be that the capsule is the problem, but make that the last thing you do and exchange. If there's ever a 50-50 situation where you think it's either needs to be exchanged because the patient hasn't been happy since day one, and you figure out it's not the ocular surface or refraction, exchange that lens before you do a YAG, because you're going to make your life or someone else's life a lot harder. And I've done it. So not saying that I haven't done that. I mean, what are your thoughts on when to pull the trigger on a YAG?
I think that's really a key moment. I used to say that if I break it, you buy it. If I open that capsule up, it's your lens. But I actually will exchange lenses pretty readily now with open capsules, but I do try to avoid it. What I want to find out from a patient who comes in who's unhappy is, were they ever happy? Were they happy for the month after the surgery? Were you happy for a while and now you're unhappy? To me, that's a clear indication that doing the capsulotomy is indicated. When a patient says to you, I haven't been happy since day one, that's the kind of patient where I am thinking very long and hard before I'm going to consider doing a capsulotomy on that patient. So I do agree. That's the last thing on my list of things that I want to do.
As we're sort of wrapping up, I want to talk a little bit about things that may seem trivial to us, but are non-trivial to patients. I had a patient that I saw in clinic, and it wasn't long after I had this discussion with you originally at the J&J users meeting, where you said never let a patient complain, and I sort of had that in the back of my mind, or the top of my mind. And this patient had a corneal abrasion, after cataract surgery. And I've told you this before, but just for those who haven't heard the story, to you and I, a corneal abrasion is probably the last thing in the world that we would ever really worry about too much. We either put ointment in a patch on, pressure patch, maybe a bandage contact lens, but we're just sort of like, okay, next day or two, you'll be a little uncomfortable, come back, you're going to be fine. Well, I had a patient who, I probably did not communicate this adequately to her and the family. Like, your surgery went great, but you have an abrasion, and that just means you're going to be uncomfortable. She was in significant pain. I'm not sure if she had low pain tolerance or it was just the way her abrasion was, but she was in significant pain. And she called back to the office, and she really felt like she got blown off. She didn't really get through to anyone. She was having this pain. She felt like it was, probably from the surgery, that something horrible has happened with her surgery, and no one's helping her, which is actually a key point that you mentioned in your article, is that you're really losing ground with patients the moment they feel abandoned. The moment they feel like you're not taking care of their needs, that's you're getting yourself in trouble there. And so that's where we probably made our first misstep. My first misstep was maybe not communicating it. The second misstep was not being responsive to when she called in saying that she's having discomfort. Well, she heals up. She comes in the next day, and okay, we explain everything. She's 20/20 uncorrected by, I think, 7 days, so 1 week, and she's scheduled for other surgery, but she's refusing to have her second surgery until we have a conference, and she wants to bring her son in, and we are going to have a conference about the first surgery and what happened and what went wrong and all this, and I'm kind of thinking to myself, oh gosh, I've got to gear up for this conversation, and I've just got to tell her, it's just a corneal abrasion. Just get over it. This happens when we put the speculum in. But I that still small voice in the back of my mind said, no, don't blow this off. Go in and tell her that you would be upset too, because if this were you and you felt this way, that anybody reasonable would be very upset. And so I took your approach and I walked into the room and I said, I'm going to say, Mrs. Jones, you know, if I were you, I would be very upset right now. We have not delivered the experience or met the standard we set for ourselves. And because of that, you went through a really bad 24 hours. And I want to take ownership of that and apologize for it and let you know I understand why you're upset. And I went through, then I from there, I just saw her blood pressure go down. She was no longer in this sort of adversarial stance. I didn't know who her son was, but he's sort of, behind me in the corner. And I just sort of go through this whole thing, letting her know that these things happen, but we're going to try our best to make sure it doesn't happen again. And just how sorry I was for how the experience that she had. At the end of it, she was consoling me. She's like, well, it wasn't that bad. And she wanted to give me a hug. And so it was ended up being a really sweet kind of moment. And she was happy to have her second surgery. The kicker of this story is her son is a medical malpractice attorney. Okay. And I didn't know that. He was just a family member. And as I was about to leave the room, he said to me, I was not sure what to expect. My mother was obviously very upset and she wanted me to be there as a support. So I agreed. But he said, you know what? He goes, I have to tell you, if more physicians handled their patient complications or dissatisfied patients the way you did, I think I might be out of a job. And so it was just a real reminder of don't blow things off just because they're not a big deal. If it's a big deal to the patient, you need to engage that and be serious about it, because those little things can matter.
What I just heard from you now is an amazing story, and you handled it extraordinarily well. But I want to identify two key elements to this beyond the way you communicated to the patient. One is that we as ophthalmologists view our success in terms of vision. Patients view pain of equal importance, and even if you have a couple hours of pain or a day of pain, they view the operation as a failure. So a lifetime of good vision is lost with one episode of discomfort. So view pain control is very important. That's why I think nonsteroidals are important. As you mentioned, using a bandaged contact lens is important. And the other aspect that you mentioned, I think is really important as well, is patients get very upset when they feel abandoned. And your patient felt abandoned because they couldn't reach anyone to get the result that they wanted. If they'd been able to talk to you right then and there, that would have solved the problem. So what I do when a patient feels abandoned, like this patient felt abandoned, I tell the patient, I don't do this very often, but I'm going to do this for you because I am really upset with what you went through. And I give the patient, I take my card, and I write my cell phone number on the patient on a card, and I hand it to the patient. I go, I almost give this to nobody, but I want you never to be in a situation where you can't reach someone important. If you can't reach the person, you don't have to call me first. But if you can't reach the person that you want to reach, you call me, and I'll make certain this gets taken care of. That shows them that you are absolutely committed to making certain that they never in that position again. So your management was extraordinary. I think those two little tidbits also add to that conversation as well.
Absolutely. And that's another thing that I'm going to put in my, I'm going to file away, Eric. I always learn things as we talk. Any final thoughts on emotional intelligence, this topic that I think is important that we bring to the forefront as we sort of wrap up?
Let me wrap up with one statement. I've said this for 20 years. I've said this. And if I had a bumper sticker on my car, this would be my bumper sticker. And that is, when you see a patient preoperatively, look for the pathologies that exist preoperatively. That's why I get an OCT on everybody, I do topography on everybody, because if you see something before surgery, that becomes an expectation. If you see the exact same problem postoperatively, and you didn't tell the patient about it before the surgery, that's your complication. So set expectations preoperatively, and I think that goes a long way to making the patient happy postoperatively.
I totally agree. I've heard you say that before, and it's something that rings true and rings in my head as I'm evaluating patients. So, Eric, thank you so much for making time for us. It's always a pleasure. I look forward to seeing you in the near future, and thanks again for all your contributions. We really appreciate it.
Gary, keep up the great work. You are extraordinary, and boy, I'm just so impressed with everything you do. And I was very privileged to talk to you today. So thank you very much as well.
Honor is mine. Until next time, this has been CRST, the podcast. Thank you.
For more shows like the one you just listened to, check out the podcast channel on itube.net.